Thank you so much for joining us for our January webinar. This is Dementia Care Aware. Today's webinar is on dementia prevention and care for Latinos in San Francisco. And really pleased to have our presenter, Serggio Lanata, and I'll be moderating and especially taking note of your questions today. So let's get going. So just so you know who we are again, and of course you'll have the slides and the recording after this session. But I'm Anna Chodos, very fortunate to be the Executive Director of Dementia Care Aware based here at UCSF. Of course, we are a DHCS program. And our presenter today is Dr. Serggio Lanata, who is a neurologist at the Memory and Aging Center here at UCSF and has been very integral to all of our work here and a lot of our educational materials. So just so you know who we are again, and of course you'll have the slides and the recording after this session. But I'm Anna Chodos, very fortunate to be the Executive Director of Dementia Care Aware based here at UCSF. Of course, we are a DHCS program. And our presenter today is Dr. Serggio Lanata, who is a neurologist at the Memory and Aging Center here at UCSF and has been very integral to all of our work here and a lot of our educational materials. So really looking forward to his talk, and also he'll introduce himself some more later during his presentation. Next slide. Really my job at the top of the hour, other than to let people filter in and give them some time to transition from what they were doing before, is to just go over some quick housekeeping and what we'll do here with this hour that we have together. We will have Q&A at the end. As you go along, though, if you have questions, please put them in the Q&A. I'll be monitoring that throughout as Dr. Lanata is giving us his talk. And we really hope to get your good questions and get to them at the end. And if people are sort of submitting similar things, I'll be sure to batch them towards the end. So really look forward to your comments. We will, right at towards the end of the hour, about 5 minutes till, we'll share information about how to get continuing education credits. We have credits for a lot of different boards and organizations, so we really hope you can take advantage of that. And we'll have a link in the chat as well as information after the webinar so you can access that. We really want you to take advantage of that. The recording will also be up. You can find it via our website, dementiacareaware.org, or on our YouTube channel to watch if you want to go back and see anything or spread the word to others. And we'll also be putting our slides up on our website. Next slide, please. I also, at the top of the hour, like to remind everybody of all the things we're doing. So I love the webinars. I always learn something, and it's a good chance to have some interaction with folks' questions. But we have so much else to offer. So we have the trainings that are online and static, essentially. They're online trainings. We also have ample opportunities to see the training live and ask questions of the presenter. So you can always find ways to sign up for that on our website. We have podcasts, which is just another way to learn the same information. So you'll hear this webinar in podcast format as well. And on top of that, we have echo style conferences, which are very, very interactive and case-based. Also, you can sign up for those on our website. And we have practice change support. So if you are a clinician or a clinic that really needs additional support for starting to do dementia care aware activities like our cognitive health assessment, which is a screening approach for dementia, then, which I'm about to go over very briefly as well, you can contact us and we can put you in touch with program support coaches essentially to help you do that. And finally, we always like to plug the warm line. It should be hovering somewhere behind me on my background, but that is a 9 to 5 warm line, meaning there's warm live adults there to answer your calls, and they're all specialists in dementia and the Dementia Care Aware program to help you navigate clinical care for people around screening and anything really having to do with dementia in California. So next slide, please. I always like to plug our training. It's sort of the foundation of everything we talk about. Our core training really goes over our approach to dementia screening, which is called the cognitive health assessment. The online version can take up to 90 minutes or less, and you get 1.5 credits for it. But it kind of goes over all the basic aspects of what dementia is and definitely how to screen for it. So now I'm just going to briefly go over what that screen is, so we're all sort of grounded in that, and then we'll get to the topic for today. Next, please. So the cognitive health assessment is meant to be usable as an approach to screening older adults, so 65 and older, for dementia, largely in primary care practice. And we also sort of include in some of our trainings how to do this with a team. For example, break it up among a primary care team, medical assistants, nurses, things like that. And the core is that we're really using a historical moment, meaning a question or a symptom that we're noticing as a brief patient history. We're using validated tools to screen for cognition and function. I would say also briefly screen for cognition and function, so short tools. And finally, we want to kickstart understanding that people have a support system or may need one. So documenting briefly, very briefly asking and documenting about someone's care partner information. Next slide. And we also want to plug that a lot of people have really started to take on to our live trainings, preferring that over our online trainings. I think both are great, but we want to make sure you know that the 1-hour sessions are free. They get you registered as having done our training, which means if you use it in clinical practice, you can bill for it as well. And you get CE, CME, and maintenance of certification credits if you participate in that program. So you can find all the information to sign up for that on our website. Next slide, please. So now I'm going to hand it over for Dr. Lanata for the talk itself. Thank you for your attention, and I will see you again at the end. Thank you, Serggio.
Great. Thank you. Thanks, Anna. All right. Thanks, everybody, for coming to this talk. These are the learning objectives today. I'll be talking about our Memory and Aging Center Community Outreach Program, and more specifically, how we are conducting outreach and engagement. Our outreach and engagement strategies directed at Latino San Franciscans. We are supported by the NIH, by the Global Brain Health Institute, and also through internal funds from our division, the Memory and Aging Center. This is the logo of our program. I think I've heard different interpretations of this logo. Be curious to hear yours. I think to start, this is the founding framework of the work that we do. We started from the understanding that Alzheimer's disease, this neuropathology, which is, the hallmark of which is the accumulation of the amyloid protein and the tau proteins in the brain. This neuropathology has been strongly associated with several medical and behavioral/lifestyle risk factors that, based on best estimates, account for maybe 40% of the cases of sporadic Alzheimer's disease. So it's very important to keep these risk factors in mind, I think, as clinicians, and that's part of the approach that we're taking with Dementia Care Aware as well. Thinking of blood pressure, cholesterol, diabetes, depression, smoking, hearing loss, obesity, as well as physical activity, sleep, social isolation, and loneliness is a big one, alcoholism, smoking, air pollution, and educational attainment. So we started to think a lot about this framework and thinking of how do we apply it to the communities, the immediate communities that we serve. Another way of looking at these risk factors is to sort of coalesce them in this kind of Venn diagram of major categories of risk factors. And this is kind of how I put them together in my head. I think that exercise and social stimulation or social engagement are nodes, meaning that if we're able to address things like exercise, physical activity, and mitigate social isolation, then sort of naturally or organically, if you want, other things kind of take care of themselves, like sleep would be a good example, right? If you engage in a regular exercise routine, we all know that that can improve sleep and so forth. So those are main nodes of these groups of risk factors. And I'm going to return to this concept in a moment. Thinking about this structure or this framework for AD and other causes of dementia is very important in California and in the country, but we're focused mostly in California here because the rates of these disorders are going up in our state. And I think the Department of Public Health did a really nice job here because they separated Alzheimer's disease from other causes of dementia. And you can see that the rates are going up globally in the state. So it's definitely, as we all know, an important condition to take care of. But then when you break this down into different racial or ethnic groups, you see that there are differences, notable differences, and namely, it turns out that Latino Americans, Latino Californians, Black African American Californians carry a higher burden of this increasing prevalence. Which begs the question of why, right? If we're focusing on this conversation in Latinos. I think there's a long tendency, a long history of trying to pinpoint these differences in outcomes to biological factors. And there really isn't a lot of scientific basis for this argument. And the American Society of Human Genetics knows this better than any other organization, or the scientists, geneticists know this better than any other scientists, I think. And they come out with these statements every now and then, trying to remind the society at large and also scientists that, you know, these racial ethnic divisions are scientifically meaningless in the sense that they're not really representing underlying biological homogeneity between groups that you can explore to try to explain the health differences that you're seeing in populations. In other words, you have to look at other factors, right? Not just biology. And we've known this for a long time, at least for sure since the completion of the Human Genome Project. Remember that one of the driving hypotheses of this project was that if we randomly sample people from different continents, we're going to see categorical or near to categorical differences between groups, but that turned out not to be the case, and in fact quite the opposite showed up based on the data. And so today a geneticist cannot really tell apart people if they're looking at just genetic data, like what they look like, what phenotype they have, and what social identity they're going to have. So it's really a poor marker of biological homogeneity. Well, naturally, then people also turn to culture. And, you know, we like to think that these social labels that we use to classify people actually have a robust categorical meaning in terms of cultural practices. And I would argue that that's not the case either. And that's not, especially not in California, because we are home to, I'm from Peru, and there's Latin Americans living here that come from very diverse backgrounds. So there's quite a lot of cultural heterogeneity among Latinos in the state. And that's only thinking about first generation. But if you add the children of the first generation immigrants, the heterogeneity widens even more. And that's because this concept of culture is very nebulous. It's very wide also. It's as you can see here, this succinct definition of culture should make you think of, you know, how do you capture this construct in a way that you can study, or in a way that you can ascribe differences in health outcomes to culture. Is very difficult because it's such a difficult concept to pinpoint. And more importantly, it's in constant flux. So when I came to live in the States, I brought with me a specific cultural identity, a set of values and practices that have definitely changed in the course of the many years that I've lived here. So it's something that is constantly changing. So therefore, very difficult to study, very difficult to tie health outcomes to, especially when you're casting these very wide nets of Latino. But nevertheless, we keep coming up with labels to try to encapsulate a group of people that you know, serve a purpose in society and how we relate to each other. I may call myself a Latino when I'm in a social gathering, but I know that that doesn't mean, when I say that, I don't expect anyone to pull up a list of things in their minds that they think they know about me. And it turns out that these new labels, like Latinx, for example, is a hugely controversial label because most people haven't heard about it. Most older adults haven't heard about it. And if they have, they don't use it because they don't have any identification with it. That's definitely the case among the Latino Californians that I engage with, both in clinic and in research. Literally none of them use this term, the older adult population that I engage with. So if the basis of these health differences when it comes to brain health, and specifically Alzheimer's disease and other causes of dementia, cannot really be boiled down to genetics and culture, then what does it boil down to? I'm talking now about the sporadic cases that are not clearly genetically driven, right? Which is the majority of cases of Alzheimer's disease. Where, well, in the past few decades, there's been emerging literature to highlight other factors, right, that are now labeled as social determinants of health, but it's more than just that, right? It's also environmental factors, economic factors. So we started looking at different maps, data-driven maps of San Francisco, things like, you know, representation of green areas, food deserts, medically underserved areas, hospitalizations per neighborhood. Actual San Francisco has really nice data about all of these factors. You know, how many fruits and vegetables people are eating per neighborhood, per zip code, sale of alcohol, and try to see correlations between these maps to see if there's a signal. And so, for instance, you can look here. This one is a little dated. This is from 2013, I believe. But, you know, these in red are the areas that are most medically underserved. And there's a nice correlation with hospitalizations for diabetes, meaning, as you all know, right? So the emergency rooms become sort of like primary care centers for people living in neighborhoods that are medically underserved, regardless of their background, regardless of their race, their ethnicity. It's an issue of income and location more than culture or biology. I guess that's the argument that I'm trying to make. So we looked at this data and other maps, and it triggered my curiosity, obviously, and others in here in the Memory and Aging Center, and thinking, okay, how can we do an approach to outreach that is more empirically based and not based on national statistics that really don't pertain to the region that we're working with. And that highlights this type of experience. This is an actual citizen of San Francisco explaining through an interview, you know, what are the factors that impede him or her from achieving the health that he or she would like. And it's more these issues. Not biology and not culture, not their ideas of health. It's just very, you know, down to the ground issues that get in the way. And it's these issues that are far more categorical, if you want to think about it, than thinking categorically about cultural identity and biology. It's these issues that are most prominent, right? And so what we did is we created a series of our own maps. So let's start with this one. Here, what I did was I compiled data that the San Francisco Department of Public Health has at a neighborhood level, not at a zip code level, but neighborhood. So that's the demarcations that you're seeing here. Looking at over 20 variables that they were collecting, things from, you know, exposures to like violent crime, all the way to, you know, sidewalks and green areas and access to public transportation, things like that. And based on that data, and I worked with a statistician to figure out how to weigh each factor and how to show this graphically. We created this heat map where the red areas are the most vulnerable. So this is what I call a vulnerability map, vulnerable based on the data that I told you. And green areas are the ones that are least vulnerable. Ignore the Golden Gate Park, but the other neighborhoods are people living in those areas. And then we created this map, which shows where people come from to our center, either to clinic or to research. And as you can see, there's a correlation between the most vulnerable neighborhoods are the least represented in our center, shown by the diameter of the dots, of the gray dots, whereas the greener areas tend to be the most represented. So that was a very eloquent way of you know, seeing where in the city we need to try to make a dent. And then if you look at the map on the right, this map was created by the city of San Francisco, showing you where do racial and ethnic minorities tend to live in what areas of the city. And you can also see a correlation that, for instance, this historically African-American Black neighborhood, the Bayview Hunters Point, which is the most vulnerable based on our data, and one of the least represented, is the one that is mostly inhabited by African-Americans. So it creates an empirical basis for why we need to do work to try to change these maps of representation. So we geared up to create an outreach program that was more place-based rather than race ethnicity-based, meaning okay, let's look at these neighborhoods where we don't have a good representation. Okay, who are the people that live there? What languages do they speak? And then we try to assemble a team that could reach out and do the work. We were later enthusiastically strengthened by, our approach was enthusiastically strengthened by this type of research that came out years, this is recent research, led by some of our colleagues actually that we work with, like Amy Kine, did a very cool analysis where they looked at brain volumes. So hippocampal volumes, for example, are a good marker of neurodegenerative disease or risk for neurodegenerative disease. And they were curious to see, okay, what do the brains look like in neighborhoods that are highly vulnerable, and correcting for race and ethnicity, right? So looking at just vulnerability and aside from race and ethnicity, and they saw a clear correlation between highly vulnerable neighborhoods. People living in highly vulnerable neighborhoods tend to have lower brain volumes compared to people living in highly affluent neighborhoods, regardless of their race and ethnicity. So I think this substantiated our approach. So basically the approach we take is we want to improve access to clinical care for Chinese, English, and Spanish-speaking older adults living in San Francisco with cognitive concerns or cognitive impairment, particularly those living in the most underserved and vulnerable neighborhoods. And I already showed you what those neighborhoods are. So there's a clinical access component to our work. Another is education. So we want to work within these neighborhoods to create brain health literacy, awareness of brain health, and strategies, or at least knowledge of what are the key risk factors that we should try to address. And with that, also tell them that we have a clinic, we have community clinics that we're working with, and also observational research projects that they might be interested in participating in. The third one is a more recent aim that came from the realization that we were not reaching or engaging, we're not as engaging as we wanted when we just offered traditional education. So we developed like a community-based arts and movement programs for brain health, and I'll tell you more about that. And lastly, since we've been successfully engaging Latinos and others in the city, that's opened up a whole new research project to try to understand how these specific exposures that I mentioned to social, environmental factors throughout the lifespan, how do they affect brain health late in life? So basically, we work across 4 main pillars. We call them pillars of action: education, the arts movement-based workshops, clinical care, and also online dissemination. I'll focus mostly on these 3. And specifically on Creative Minds, which is a grant that we obtained from the city of San Francisco to build the arts programming that we offer Latinos and other groups here in the city. And a little bit about the education that we do, which we do in partnership with physical sites in the city, and also in partnership with organizations that don't have a site, but they do a lot of work around education, like the Alzheimer's Association. And then in the arm of clinical care, what we've done, and Ana Chodos and I work together around this aim as well, is we've partnered with clinics within the San Francisco Health Network to bring specialty level care to these clinics. Because what we've learned is that many times people, they really wish to get all their care in their community site, and asking them to travel to the general hospital, the main hospital, or to one of our subspecialty clinics is quite a hassle due to economic reasons, transportation, or simply preference. So we've created partnerships with these sites. Some sites are off the San Francisco Health Network, like the Mission Neighborhood Health Center. That's its own clinic that serves primarily Latinos in San Francisco. And we've also been collaborating with Anna's Geriatrics Neurology Cognitive Clinic to serve these populations. We recently updated our grant for the Alzheimer's Disease Research Center here in the Memory and Aging Center. So we listed all of the partners that we have. They ask us to divide partnerships by race, ethnicity. I would prefer to divide things by neighborhood and by vulnerability. But this is a list of the partners that we've been working with throughout the past 5-6 years. We don't work with all of them at the same time. Obviously, we kind of go through cycles. But just to give you a sense of the breadth of the collaborations that we've developed over 6 years or so, working with senior centers, community centers, consulates, community clinics, and like I said, organizations that don't have brick structures, to try to bring our mission to them. This is a snapshot of the work that we did in 2021, 2022, that shows you, the amount of events, and this is just highlighting the virtual events. So we do virtual and in-person events. So for Chinese outreach, we did 19, Spanish Latino, we did 76 individual events, African American 45, and Filipino outreach, which is something that we're just starting to roll out here in the Memory and Aging Center, led by Jessica De Leon, one of our colleagues, also picking up in terms of education. We do a lot of events with Alzheimer's Association directed at Latinos, also with Family Caregiver Alliance. So that's a key. If you want to do outreach, try to find not only physical spaces with whom you can engage and actually go to these places and deliver your content. And well, obviously, first step, what are they interested in learning about, and then deciding what type of content you're gonna deliver. But also with big organizations, national ones like Alzheimer's Association, because they have satellites throughout the country that you can partner with. So we've been doing this for years, like an annual Latino conference in San Jose or up north. We recently did one here in San Francisco focused on caregivers. A lot of virtual events. This has been key. This has been I would say, something positive that has emerged from COVID, because initially we thought that there was going to be a lot of challenge to get older adults from vulnerable backgrounds to engage through Zoom, but that didn't turn out to be the case. A lot of interest in Zoom-based engagements, either directly to their homes or seniors coming to a center, and then there's a screen there. And so it's a hybrid model where some of them will go to a place to participate and others will stay home. And we are delivering the content from the Memory and Aging Center. It's allowed us to really expand the number of attendees as well. Makes it a lot easier because of communication, because of transportation barriers and other barriers. But we've kept doing in-person events. Super important. This is one that we do every year. We call it a research education event because many of the Latinos and other groups that we engage with, they end up expressing interest in participating in observational research because they get an opportunity to not only contribute to science, but also get feedback of how we see their brain health, because each participant gets a summary of how we, of our findings. And so what we do is every year we meet with all of the participants and share some of the knowledge that we're gaining from their participation. This one was this is 2022. We had 85 people attend, and it also helps us, gather some feedback about the experience through research. Switching over to the clinics, and also showing you that most of the physical partners that we've engaged with in the city are located within these neighborhoods that are highly vulnerable and highly underrepresented. That's what I want to show here. This is not updated, but it gives you a sense. And I'm also in red showing you the locations of the clinics with whom we're working with, meaning that we go to these clinics and try to provide the same level of care that, at least in initial consultations, that we provide here in the Memory and Aging Center. So that means that for some of these clinics, I'm able to go with a neuropsychologist, for example, and do full neuropsychological evaluations. Our hope is that we're going to bring more team members so we can have a social worker that can support these clinical efforts as well. The art and movement base has been so so enriching, and it's really beautiful work to do in the community. If you're considering doing outreach, I would say start here, start with arts and other types of engagements. This goes back to what I said earlier. I see exercise and movement and social isolation as two nodes that if you tackle those, then the other factors tend to improve by themselves almost, or there's at least motivation to take care of yourself in other ways, right? So we created this program. It's called Creative Minds, and we did it in partnership with a group of artists that were training with us in the Memory and Aging Center as part of a program called the Global Brain Health Institute. And we were lucky to obtain funding from the city to support this program. It's still being funded by the city up until 2028, I believe. And what we do is, in partnership with the partners that we have already created, we bring arts and movement activities into these senior centers and other partners. And this has been a great way of tackling these two very important risk factors, but also a great way of bringing education in a different setting. So what we do is we develop these multi-week arts-based engagements. For example, we have a photographer that is working with us. His picture is not here, but he teaches seniors, people older than 65, about photography, how to take a good photograph. It's a series of workshops. And then we intersperse that with brain health education. So myself and my colleagues will show up, talk about creativity and the brain, for example, and then offer our services, the clinic, research, and naturally people show interest, and it kind of opens up a more friendly, maybe, or just a different mindset about talking about these issues that are important for community health. So we did, for what you're looking at here is a celebration. We do a once-a-year celebration of Creative Minds, where we showcase all of the art that participants have done throughout the year, and they invite their families. And then we have these brain health discussions in different languages during the exhibition that is usually a multi-day exhibition. So this is the one that we did last year. And this one, what you're looking at here, is a conglomeration of little tiles that participants would paint on, and then you coalesce them together into the shape of a brain all around the theme, and they would see their work exhibited. It was really, really cool. This is us putting together the exhibit. This is one of the projects that we did. It's called body mapping, where the participant would trace their own bodies on a big canvas, and then reflect on the experience, on their lived experience through COVID. How did COVID affect them? What parts of their body they felt were being affected, and more than just parts of the body, their emotional health and mental health. This is one of the participants. This is their body map, and these are their family members. And basically, he's just explaining the process. It was really, really enriching, and participants were really very grateful for the experience. This is Magda, one of the artists that has led the movement component. She's still working with us remotely, and basically showing the work that she had been doing over multiple series, all Zoom-based. So teaching participants to stay active while sitting through Zoom. Very good reviews from participants of all ages. There's many ways of showing success, I think. You measure it by how many people you take care of in these community clinics, and how many education events, the feedback that you get, obviously, the demand for more education. This is just one other way that you can show success of engagement, meaning that translate to trust, because people naturally show interest in participating in research. So this is just showing like how successful we've been at bringing people into our Alzheimer's disease research center across these different groups. And like I said before, we give back by offering an assessment, a clinical a summary of our clinical impressions of how they do in research. And if we find something that worries us, then we facilitate the referral to clinic as well. So that's how we give back. All right, to start to wrap things up a little bit, I want to focus a little bit on the fourth goal of our outreach and how we are approaching this one. So I started telling you, that it's not so much biology and it's not so much culture. It's more exposures and how they accumulate over time, and that how they can lead to these differences in health outcomes that we're seeing, in this case, across brain health. So we want to really tackle that question or that area of research. And so that leads to a little bit of life course epidemiology 101. And there's basically two broad theories from what I can glean. I'm not an expert here, but based on my review of the literature, there's two big models. There's the accumulation model and the critical sensitive model. The critical sensitive model argues that exposures to the social and environmental factors matter more during certain times of life, like childhood. And that's why there's a lot of emphasis on ACEs, right? Adverse childhood experiences, because they would argue that those exposures, you embody them and you carry them through the rest of your life, and they have an impact on late life health. But there's other epidemiologists that are more engaged with the accumulation model, and they would say that timing is less relevant, and that what matters more is the cumulative duration of the exposure through all the life periods. I feel like, me personally as a clinician, I tend to agree more with the accumulation model. I think both are valid, obviously, and I think that's what the epidemiologists, the consensus is that. But the question is, how do you approach it, right? Do you want to focus only on one time period, or try to grasp all of the time periods across many exposures? And that's the approach that we took. We took the approach of, why don't we develop a questionnaire that is informed by our clinical practice here, as well as everything that I've shown you, the data that San Francisco has, to develop one questionnaire that captures exposures across the entire life of the individual, and then start to understand, maybe through a case control study, how do these exposures influence brain health. So a few years ago, we began the process of developing this questionnaire, asking a lot of questions from people across many different domains, some of which are listed here. So this turned out to be a fairly long questionnaire, a little hesitant at the beginning, because we thought maybe people were not going to be interested in engaging with it, or maybe it was going to resurface a lot of traumatic experiences that people were going to, push back on. But no, that has not happened at all. So we offer $80 per submitted questionnaire. And these numbers are not updated. We have a higher number of respondents now. It's all done electronically through RedCap. And we're administering this questionnaire to existing research participants in our cohorts, including the Latinos. And it takes around 40 to 60 minutes to complete. We haven't received a single complaint about the content, and we're asking hard questions about exposures to violence, traumatic experiences. And we have a protocol that we follow if people respond about recent events. Most of the barriers are around lack of access to computer or low computer literacy, or some people that do not engage at all. We think that they're not getting the emails. So we're thinking of another strategy to get everybody, as many people as possible, engaged with this project. But we've been fairly successful. And we started to look at this data, just purely descriptive and comparing. So let's compare like Latinos in San Francisco or the Bay Area that are participants in our projects compared to non-Latino whites. And not surprisingly to me, there aren't categorical differences between groups. And so what you do is you do a PCA-generated analysis to see, okay, where are the differences? And most of the significant differences between groups fall in this domain of education, access, and quality. Basically, not so much in economic factors, interestingly, although there is a difference, and not so much in neighborhood and built environment, and not so much in social and community context. This includes things like experiences of discrimination and other factors. It's mostly education and economic. When you just look at, when you compare groups, which was interesting. You can also, I mean, we're still in the early phases of gathering the data, so I don't have a lot of data to share, but we've begun to do some preliminary analysis looking at, okay, now if you look at people that are showing signs of cognitive impairment compared to those that aren't, and then looking back at their life, one of the things we looked at is like, we ask about appliances, number of appliances in your household at different times of life. There's good research that shows that this is a indirect marker of economic attainment. And we see these differences showing up, which is interesting to look at. So again, the purpose here is to not fall back on these labels, Latinx, Latino, but actually look at the underlying factors and try to pinpoint those and see what effect they have later in life. Wei Ming Watson, a PhD postdoc here in the Memory and Aging Center, is interested in adverse childhood experiences across racial ethnic groups and see how they affect late life cognition. And she's already seeing signals even with the little numbers that we have. So we're hoping to gather this information from all Latinos that or as many as we can, that engage with us in research, as well as other groups. I'm hoping that we'll eventually have around 500 people or so, and generate more robust analyses and have more hypotheses to test. And to finish, everything I've said here is basically a quick representation of the work of many people, some of which are shown here. Myself, Poon Lee T, who leads the Chinese outreach, Charles Windon, who leads the outreach directed at African American, Blacks in San Francisco and the Bay Area, Jessica De Leon, who's leading Tagalog or Filipino American, and all the people that support these efforts within the Memory and Aging Center. We work collaboratively across projects and groups. That's also very important, to try to have a group of people that are willing to work across efforts. If you have questions, feel free to email me, Serggio Lanata at ucsf.edu.
Wow, Sergio, that was, yeah, this is, we always have a slide on our warm line. You'll see it on our handouts again. There's a lot to think about, and the time went by so smoothly. I think it's a real testament to your amazing presentation style. I was kind of like trying to take in all the work that you've done and try to think of the implications, or like how other people who might be listening who work in clinical care or in their area have a very, maybe they live in a more rural area, or they just have a different environment around them, kind of what some of these implications might be. And of course, the implications for like general primary care and clinical care. So
Yeah.
I have some questions for you. And then I want to get your take. I answered a question about some of the risk factors for dementia. I think you've brought in that conversation today as well, but we'll get back to that. I just want to reassure the person who submitted that question. So I think one of my first questions is, like, if I'm to summarize some of what you said, is, you're really taking a vulnerability and, additional factors approach to, some of which are like over an entire lifespan, kind of no matter how or who they are, today, present, because we're usually dealing with older adults. So they may be living in a neighborhood in the Bayview, but perhaps most of their life live somewhere else. And you're sort of doing this incredibly deep dive to figure out what are some of the factors that are most helpful to us to know who's at highest risk. And right now, things like Latino or Black African American or Asian designators, as people are able to identify those, like, might help us frankly, like, shortcut a little bit who's highest risk. Certainly a lot of the data is based on these things. So we're hoping to reduce these disparities because they're clearly there and relevant, but you're saying there's these like bigger factors at play. So I'm wondering if, as we're screening people, as we're recognizing people's backgrounds and all the things they're bringing into these clinical encounters, are there some maybe, it sounds like to me, like what I'll be more attentive to maybe is neighborhood. And I know, when we're doing dementia, we're often asking about education anyway,
Yeah.
but are there any sort of like factors now that early on you might advocate incorporating into our understanding of someone's risk?
Yeah, I think as we've thought about this a lot, right, in our clinic, in the GNCC, and how we approach that interview, because the way I start my evaluations is trying to get to know the person first. Meaning the way we do this is like you want to get to know, okay, where do you live? Tell me a little bit about your background, and then you'll start to hear the life story, and that doesn't take a long time, obviously, and that helps you frame the vulnerability of this individual, and basically that should be the approach, right? And the example I make is like if you're basing your approach to outreach on these labels that are most of which are based on nationally acquired data, when you look at health disparities or even states, you got to put yourself in different situations. Like if you're doing Latino outreach in Miami, Florida, that experience is very different than doing Latino outreach here. And it depends on what region of Florida you're talking about. There's highly affluent Latinos in Florida. One would argue, like, what's the point of doing Latino outreach in Florida? Because, they're not as vulnerable as a group as are Latinos in California. But then if you think only of San Francisco, right? I have patients that are Latino, they identify as Latino socially, but they have dramatically different backgrounds. Some live in affluent neighborhoods and some live in extremely poor conditions, right? So how helpful is the Latino label is the question that I always ask myself. It's like, Latinos are, fill the blank. Like, what are, and what's that R that you can really confidently put your feet on and say, like, this label actually means something to me as a clinician or researcher, and this is what it means. That's the issue that I have with, I'm not opposed to the use of the labels. I mean, in society, we can call ourselves whatever we want, but does that translate really, like, to actual care and research? That's where it gets a little complicated. As you and I know, people that in San Francisco, most people live where they live, not out of choice. They end up living in the neighborhood that they can afford, because conditions are so crazy in our state, especially along the coast. So the economic factor is so immense. And it's only a few residents of our city that have the luxury of saying, I want to live in Presidio. I want to live in Noe Valley. I want to live because it's beautiful, right? But no, that's just not the reality. So I would argue that regardless of your race and background, if you're living in a highly underserved neighborhood, highly vulnerable, and you've lived there for most of your adult life, you're probably going to embody the same vulnerability, not the same, but similar as the average of that neighborhood, right? I think that's a reasonable hypothesis to study. And so that's what's guiding our thinking.
Yeah, I think, and just imagining a future where that's like very usable information too, I think is really interesting. I mean, also, I just want to highlight in your presentation, I think the things that it also really inspired me to think about as someone trying to improve dementia detection and care just generally would be like your guys' approach is not only, we're trying to improve individual care, but like we're really looking at the entire environment and what's really accessible that supports brain health. So, like some of the programs just absolutely, inspiring and stunning to think that, people have more community programs that really foster connection, the social engagement, the artistic aspects of their lives, and an understanding of their brain health. Yeah, so it's sort of like, how are we going to do a better job clinically understanding the risk factors and for each person coming in front of us, but also how are we going to build the resources in the community for brain health and for clinical care. So very, very, very cool.
Yeah.
I want to just get to one person's question, and I will say we're about to put in the chat for everybody who wants CME or CE. That link will be in there shortly, and you can use that to claim your credits. So look out for that if that's of interest. Somebody did bring up, and these are huge, huge environmental risk factors and individual risk factors from the very beginning of your presentation. Air pollution, hearing loss. These are coming up as major modifiable risk factors. So we certainly hope air will be cleaner one day and hearing loss will be lessened. But the question is how. So they asked why those things affect dementia. And I gave my answers of maybe air pollutions that we don't totally know, but air pollution causing inflammation of some sort, and that being like a common risk factor for various diseases of inflammation, of which dementia is likely one. And then hearing loss, I've heard different explanations, but one that it causes cognitive strain because you can't really make sense of things. So you're working harder to do that. And that actually kind of pulls the brain down or makes it work harder over a shorter period of time and accelerates decline. Do you have more information to add to that?
I'm not aware of good studies and we haven't discussed any studies here that delve into the mechanisms of hearing loss and increased dementia risk. It's very interesting that it showed up as one of the factors in the large epidemiological studies that have looked at this. Another theory I've heard that could be tested, but probably hard, is just that, if you start, and remember, the issue is people that become hearing impaired starting in midlife. That's where it becomes like a potent risk factor. So some people argue that maybe it's a long period of diminished cognitive stimulation in a way, because if you're not being stimulated through your senses, then you lose out on that stream. And what I tell my patients is like, you're not going to remember things if you're not listening to them clearly. Like the message is not coming in. Well, naturally, you're going to have trouble with memory. But that's when they're like already having cognitive issues when they're older adults. But I think we will learn more about underlying mechanisms to this epidemiological association in the coming decades, but I don't know what the mechanism is.
Yeah, I think that was really helpful additional information because my understanding is it's still, if we can learn, we'll continue to learn more. Although it's a wonderful plug for all of us detecting hearing impairment and correcting it as soon as possible. Urging people to work on correction. Okay, great. Some more questions are coming through. So, and I think this gets to what I was saying is a lot of your work is looking so upstream. Like Dr., I think her last name was Watson, her work looking at, ACEs, universal childhood experience. Of course, first of all, who does not want to prevent that? But, clearly, like how as clinicians can we feel, let's just say, more empowered, or what tools would we be using to look at these vulnerabilities that we can help address versus not? So what is the provider role in addressing some of these vulnerabilities, knowing that some are like early life, factors? So do you have any additional suggestions on tools we can use?
Well, in terms of screening, there are a bunch of like very brief social determinants of health screens out there. I have a folder with some of them. And actually, that was the challenge that we had when we started this project, because most of the screens out there take the approach of the time period approach. And there wasn't one that would take all main domains across the life course. So we had to build it based on the snapshots and based on our clinical experience. But what can a provider do? I don't know. I feel like, I can speak for myself. I think that it's so hard to change these structures. Obviously, it's not our role, I don't think, as a provider to try to get in there and change the structure. We can't, right? I feel like I am in a position, in a very fortunate position, because I'm supported to do this work where I can actually create teams and and go out to these sites, not with the goal of changing the infrastructure in there, but saying, hey, we can come in and try to do the best we can, you know, with what we have. And we're hoping that we're going to bring in a bigger team and offer you the same level of care that you would receive if you come to our clinic. So it's a very small goal, but I think that's the way to do it. You know, basically just go and do the work and do what you can and hope that people are appreciative. And so far it's been working because, you know, I was surprised early on. I met, for instance, in this clinic, the Mission Neighborhood Health Center, who serves a large proportion of Latinos in San Francisco. In talking initial meetings with staff there and doctors, I would hear, you know, some of our patients, they just do not want to leave the Mission Neighborhood Health Center. They want to get all their care here. Because initially I was like, how do we create pipelines to the MAC, to the Memory and Aging Center? And they were like, that's not going to work, you know, probably because people do not want to leave. They want to get everything here. They're used to this place. So they learned that early. So they brought like dental services. They brought all these different providers to do their work there. So I just did it too. You know, I just like, okay, we'll make it work. Yeah.
Yeah, I'll add that. I mean, again, I think one thing you're doing is strengthening the local resources to just do the evaluations. And I think if we're sort of a generalist and we need to know where to start, it seems like, I mean, sort of already the recognition and the tools to address social determinants of health hopefully will help somewhat. But that maybe there's kind of still this gap of understanding of what vulnerabilities are there to kind of tell us what risks are there and what vulnerabilities are there to tell us like what we can intervene on as well. Obviously, we're not going to go back and like help people, you know, have more economic stability earlier in life, which might have had a big impact.
Yeah.
But we certainly understand that this is a higher risk population, one where, and this is, you know, part of the mission of Dementia Care Aware would be, let's at least screen, see if there's an issue and if there's something we can do to support that brain now. And to,
you know, frankly, I see it as an integral part of gathering a good history. You're just trying to get a sense of the person that you're meeting. You know, it's like, okay, what is your life like? And that helps you as a provider determine how challenging is it going to be for this person to actually implement the things that I think are going to be helpful. It's a way of triaging people too. Like if I meet a Latino that has very little vulnerabilities in their day-to-day life, then that person goes down on my list of priority compared to someone that is a recent immigrant, is living in a room with a shared bathroom and no kitchen. And, you know, these things, you can't ask this person, you know, a lot. So it's part of gathering a history, basically. Yeah,
and I know for me as well, I try to think when we sort of detect some of these vulnerabilities more about how, like just how many social services, you know, might they be interested in or additional connections, and can we start to like bring those to bear on their situation. Obviously, every local area is really a whole new world in terms of what those resources are. So I will leave it there since we're at the top of the hour. I think there's so much to talk about here in terms of, but it also just makes me think our future is going to be really interesting and really different in terms of how we're able to, you know, assess people, reach them, and really understand their risks. So I don't know, I'm feeling very enlightened and very grateful. Sergio, thank you so much for this talk today and sharing your work.
Thank you. Thanks for inviting me, and see you around.
Yeah, thank you so much. And thank you everybody for coming today.
Bye-bye.